We'll talk about a few pathologies related to the eyelid in this video. So to start with, we've got hordeolum, which is a stye, and it's classified as externa or an interna. And externa is the infection of the glands of Zeus or the glands of Mole, whereas interna is the infection of the meibomian glands. So the management of both is hot compresses and some analgesia. You can give antibiotics if you suspect conjunctivitis. Similarly, a chalazion is a blockage in the meibomian glands causing inflammation, and it presents with a painless hard lump or cyst within the eyelid, and these usually resolve spontaneously, but if it doesn't, you can manage surgically. Moving on to cellulitis, this can be split into periorbital or orbital, orbital being a massive red flag and requires hospital admission, whereas periorbital is less concerning. It is inflammation of the eyelid tissues anterior or superior to the orbital septum, usually due to a superficial tissue injury. But it is more concerning in children because this could be secondary to occult underlying bacteriosinusitis, or more rarely bacteremia spread from a primary infection, and this can rapidly progress to orbital cellulitis in children. To manage this, we give oral or IV empirical antibiotics, and you would do incision and drainage and culture the periocular abscess, and then you would switch to targeted antibiotics once cultured results are back. Orbital cellulitis, on the other hand, is infection posterior or deep to the orbital septum and affects the muscles and fats within the orbit, so it does not involve the globe, and it's usually due to an underlying bacterial sinusitis. Essentially, it is a compartment syndrome of the eye. It is more common in children and in boys especially, and other risk factors include not being vaccinated for Haemophilus influenza type B or trauma. So these patients will present with an acutely red swollen eye because of soft tissue swelling. They will be in extreme pain, which limits their eye movements, and that can lead to diplopia as well. They have a reduced visual acuity, which helps differentiate it from periorbital cellulitis, because in periorbital cellulitis you will preserve your vision, and the reason why you don't preserve your vision in orbital cellulitis is because you will likely have optic nerve compression, and so you have a rapidly declining vision is a sign of developing an orbital compartment syndrome. Other signs include proptosis, which is a bulging eye, and you can get eyelid edema, that is usually an early sign. You can have systemic symptoms like high temperature. So when you're doing an examination, you'll notice a reduced visual acuity. Always check for RAPD because visual loss due to an increased intraocular pressure will be very concerning. You'll also notice dysmotility because the eye can't move very much due to the pain. You'll see proptosis, eyelid edema, and erythema. Do an urgent CT sinus and orbits with contrast, and that will show inflammation of orbital tissues deep to the septum. Obviously, do some bloods as well, and inflammatory markers will be raised. So management-wise, give IV empirical antibiotics, so such as cefalozin, and then give more targeted antibiotics once MCNS has been done. If you suspect MRSA, then you would opt to give vancomycin and cefotaxime or clindamycin. If a patient is immunosuppressed or has diabetes, you may suspect a fungal infection, in which case you give antifungals. You may or may not need surgery, in which case you will do an orbitotomy and drainage of the abscess. If you need to urgently release high intraocular pressure, or you're worried about decreased visual acuity, or if there's RAPD, then you may want to do a lateral canthotomy and cantholysis before you do the orbitotomy. What that is just a exposure of the lateral canthal tendon. So possible complications include subperiosteal or intracranial abscesses, cavernous sinus thrombosis, and what we're really worried about is loss of vision. So moving on to the conjunctiva, we'll talk about conjunctivitis, and that is the inflammation of the conjunctival lining of inner lids and globe, and that can be uni or bilateral. So conjunctivitis can be allergic conjunctivitis, and that is the most common one, so typically related to hay fevers, atopes, vernal diseases, and you're very hypersensitive to airborne antigens. It can be seasonal or all year round, and often you'll get symptoms like edema or nasal symptoms. And in more severe cases where you get chronic allergic changes often involving the limbus, you want to treat with topical steroids and mast cell stabilizers such as iodoxamide and antihistamines. So conjunctivitis can also be infective. So bacterial conjunctivitis often looks sticky. You have bilateral red eyes and you get discharged, having crusty lid margins. Very common in children, and it's commonly caused by staph or strep or Haemophilus, and it's very contagious. And usually this is self-resolving with a bit of hygiene advice, and if severe, you can give some antibiotics and lubricants. But if chlamydia was the causative pathogen, then you want to treat with tetracycline ointment. If the genitals are involved, then you want to give systemic treatment. Don't forget georeferral and contact tracing as well. Viral conjunctivitis is usually caused by adenovirus, so the virus of the common cold, and it may last up to 2 weeks. You often get watery discharges, and you may get some follicles on the inner eyelids. It is self-resolving. Differential diagnosis of follicular conjunctivitis would include molluscum contagiosum, which is uncommon, but it would typically present in primary school age children, and it would give red eye if the lesion was in the lids, and you manage with curettage. Another one is primary herpes simplex, where you get vesicles around the lids, and you'd manage with a cyclovir or ganciclovir ointment or oral. Examples of inflammatory conjunctivitis include reactive arthritis, Stevens-Johnson syndrome. Often these are triggered by infection. Ophthalmic neonatorium usually presents within 1 to 2 weeks after birth with purulent conjunctivitis. If untreated, can lead to scarring and perforation. Often these are caused by gonorrhea or chlamydia, chlamydia being more common in the Western world and associated with pneumonitis at birth, and gonorrhea is more common in sub-Saharan Africa. Lastly, giant pupillary conjunctivitis is a response to mechanical trauma, for example, long-term or unintentional overnight wear of contact lenses. Within the conjunctiva, subconjunctival hemorrhage can also cause a red eye. This is usually caused by trauma and usually benign, often associated with valsalva hemorrhage, such as coughing or straining on the toilet. You're more predisposed to it if you have hypertension. These patients present with a diffuse patch of vivid red colour in the eye. These appear red rather than blue like a bruise because the eye is close to the surface, so the hemoglobins get more oxygenated. If they're normally fitting well, then you do not need to do a clotting screen and it will resolve spontaneously. Just to note that there are other causes of red eye that's not covered here, such as acute thyroid eye disease and caroticovernous fistula. The last point I want to make is that vision is preserved in all the causes of red eye that we've covered here in this video today, apart from orbital cellulitis. Thank you very much for listening. This will be the last video of the external eye and eyelid series. Please attempt the quiz and fill in the feedback form.